So we are group one. My group consists of Joyce, Asamiha, myself, Negash, and Surya. We are going to be taking you through hormonal contraceptives. So hormonal contraceptives are drugs that contain small amounts of synthetic estrogen and or progestin hormones. Hormonal contraceptives prevent pregnancy by mainly suppressing the hypothalamic pituitary system, therefore preventing the process of ovulation from occurring. There are different types of hormonal contraceptives, and they are chosen depending on their efficacy, safety, the patient's preference, and compliance level in taking the medications, as well as the cost that it will cost them. So the hormonal contraceptives, they include oral contraceptive pills, the implant, injectables, contraceptive vaginal ring, contraceptive patch. So I'll take you through oral contraceptive pills. There are different types of oral contraceptive pills. They include the combined oral contraceptive pill, the progestin-only contraceptive pill, and the emergency contraceptive pill. So for the combined oral contraceptive pill, because it's combined, it has both estrogen and progestin, and it has a theoretical efficacy of 99.9%, and it's the most commonly used oral contraceptive in the US. The synthetic estrogen that is present is ethinyl estradiol, which is favored or also can be mestranol. While the progestin derivative present is 7-alpha-alkyl-19 nortestosterone. The estrogen content in most combined OCPs is between 30 to 35 micrograms, and the progestin content can vary because of the difference in the potencies of the progestin derivatives. They come as 28-day packs with 21 pills containing active ingredients and 7 pills containing inert ingredients. So also the other 28-day pills that come with, some 28-day pills have 24 pills containing the active ingredients and 4 with inert ingredients, and they are known as shortened pill-free interval. They can also be packaged as 21-day pill packs, so they don't have the 7 inert ingredient pills, or they can also come as continuous dosing or extended cycle pills, which are also known as the 91-day combined oral contraceptive pills that has 84 pills containing the active ingredients and 7 pills containing inert ingredients. So the combined OCPs are either monophasic, biphasic, or triphasic. The monophasic preparations, they contain a fixed amount of estrogen and progestin in the 21 pills that contain the active ingredients. Biphasic and triphasic preparations contain 2 or 3 different pills that have varying amounts of estrogen and progestin and that are taken at different times during the cycle for the 21 days. So some examples of combined oral contraceptives include the microgynon, which is commonly sold in Kenya as Femiplan, the Marcelon, Diane, Loginon, Microclat, Microval, and Nodate. So how they work, the combined OCPs prevent ovulation. They do this by suppressing the FSH, the follicle stimulating hormone, and the luteinizing hormone levels in the plasma, and they cause the mid-cycle surge of LH to be absent. The estrogens are most active in inhibiting the release of follicle stimulating hormone, but when in high doses can also inhibit release of luteinizing hormone. However, in the combined oral contraceptive pill, estrogen is in low doses. Therefore, the progestin is the one that is responsible for the suppression of the luteinizing hormone. The steroids are also likely to affect the transport of the sperm into the fallopian tube. and the progestin causes thickening of the cervical mucus, making it difficult for the sperm to penetrate, and it also makes the endometrium unsuitable for implantation. So how they are administered. So the 28-day pack, so these ones, they have 21 pills that are containing active ingredients and 7 pills that have inert ingredients. So you should take the 21 active pills for daily, consecutively, and then when the 21 days are over, now you can take the 7 pills that have inert ingredients. And then the 21-day pack, the tablets should be taken daily for 21 days, starting on the first day of the menstrual cycle. Then this is followed by a period of 7 days where no birth control is taken. For the 91-day pack, the 84 pills containing the active ingredient are taken consecutive for 84 days daily, and at the same time, then followed by a 7-day period of inert pills. This means that the patient only menstruates after the 84 days. So if you take this 91-day pack in the course of a year, you will only menstruate for 4 times in the year, because for the 84 days, you won't be menstruating, and then when you take the inert pills is when you menstruate. Yeah. There's also a continuous method of taking the pills that can be advised to patients. This is where the patient takes the pills containing the active ingredient for 21 days, and instead of taking the placebo or not taking the contraceptive pills for the following 7 days, they start on a new pack immediately, and they start with the pills containing the active ingredients. So this method entails missing one's period altogether. The patient should be advised that in order for the pills to be highly effective, they have to be taken at the same time throughout the 28 or 21 days. So I saw when I was researching, we saw that some websites also recommend that you set an alarm so that you can always remember to take them at the same time, because when you take them at the same time, the chances of you getting pregnant are lowered completely. Missing a day's dose can lower the effectiveness of combined oral contraceptive pills, so the patient should be very compliant. When the pills are not started on the first day of the menstrual cycle, but on or after the 5th day, additional contraceptive methods such as condoms should be used for 7 days, because if you start on the 5th day or after the 5th day, you are not assured of complete safety or prevention of pregnancy for 7 days. So therefore, in order to prevent you from getting pregnant, you need to use another contraceptive method for those 7 days. So this is how you take them. As you can see, there's where the biro is the first day. So the yellow pills are the ones that contain the active ingredients. So you take them consecutively for the 21 days. And then after you're done with them, now you can take the inert pills for the following 7 days. And then you should take them in the order that they are written. Hi. So the adverse effects of the combined oral contraceptive pill include breakthrough bleeding or spotting, which is more common when you're taking the continuous dosing or extended cycle pills. These are those 91-day pills. There's also breast tenderness, elevated blood pressure, headaches, nausea, and bloating. So you shouldn't take combined oral contraceptive pills if you have a history of thromboembolic, coronary, and cerebrovascular disease. This is because we know that estrogen has a role in playing that it heightens the risk of getting the thromboembolic diseases. Severe hypertension, active liver disease, hepatoma, or history of jaundice during previous pregnancy, suspected or severe breast cancer or malignancy of the genitals, porphyria, impending major surgery. Then the minor contraindications. This one, you can it's not very advisable. So when you have diabetes, obesity, when you are smoking, when you have mental illness, when you have age above 35 years, when you have migraines, gallbladder disease, and uterine myoma. So for the progestin-only pills, they're also known as the mini pill. They are not used commonly like the other combined oral contraceptive pills. This is because they have a lower theoretical efficacy and also have a higher incidence of getting the side effects. However, these progestin-only pills lower the risk of causing
Apart from that, what else? Huh? Oh, the breast cancer. So, by the way, one of the risk factor for breast cancer is use of hormonal contraceptive, but according to the current evidence, the risk is very minimal. So even the risk usually occurs after several years, like after more than 10 years of taking oral contraceptive. Of course, the patient I encounter, like a breast cancer patient I encounter, some of them, they have actually history of like long-term use of contraceptive. But according to the current evidence, the risk is actually very minimal, but it is a risk factor for the occurrence of breast cancer. So it's really very hard, by the way. Yeah? So how do you convince even the patient, like if this is a contraceptive that can prevent pregnancy but increases the risk of breast cancer? So it is really very tough, but according to the evidence, like it is very minimal and it usually happens for long after several years of use. The next slide. So about the DM, next slide, please. The minor contraindication. Yes, about the DM, by the estrogen component, it actually prevents the release of insulin from the pancreas. So there is a possibility of insulin resistance. So in generally speaking, when a patient is taking combined hormonal contraceptive, it is relatively contraindicated in diabetic patient because it can exacerbate the condition. Then smoking and above 35 years of age is related to thromboembolism. So like the older the age, the risk of thromboembolism with combined oral contraceptive will be very high. So for someone who is a smoker, someone who is actually obese, when someone is above 35 years old, this like combined hormonal contraceptive will not be is not as effective. But then if I'm the person who is actually supposed to choose a contraceptive, I will not advise to use combined hormonal contraceptive because of the effect of estrogen is very detrimental. And of course, the concentration of, if you look at the strengths of those contraceptive, they are very minute. The amount of like estrogen is very minimal. Then the gallbladder, have already said, it is just as a result of like cholestasis. Yeah? If it actually reduces bile flow, there is a possibility of gallstone formation will be very high. And some of the combined hormonal contraceptive normally causes headache. Yeah? Some of them, they relieve headache. Some of them, they actually even cause headache. So in general, when someone is having migraine type of headache, it is not advisable to take combined hormonal contraceptives. So otherwise, what Angela presented is really very adequate in terms of the mechanism of action of the combined hormonal contraceptive. So you can continue.
Sir, question.
Okay.
Why is it that these oral contraceptives are usually contraindicated with broad spectrum antibiotics? Is it because of the liver functions?
Good question, by the way. This one is true, and especially at the pharmacies, contraceptive failure is really very common. If you are working in the community pharmacy setting, you'll encounter like the patient Even recently I encountered like one case, it's like 3 months ago. Like I encountered one case, like she has been using contraceptive and it has failed. Then, especially with the combined hormonal contraceptive, we need to be very careful, especially when we are combined broad spectrum antimicrobial agent because of intrahepatic recirculation. Remember, the estrogen component of the combined one undergo intrahepatic recirculation. That means like the estrogen conjugated to the liver, then it comes to the intestine. Then after that, in the intestine, it is supposed to be deconjugated by the normal flora, like the microorganism we're having in the intestine. So when it is deconjugated, by the way, it can actually like now the estrogen is highly lipophilic so that it can go back to the liver and undergo recirculation. In such a way, there is a possibility of like having a longer duration of action, like to control a pregnancy. However, when you give broad spectrum antimicrobial agent, once it is conjugated in the liver and actually go back to the intestine, now it is highly polar. Now, like the conjugated product of estrogen is highly polar. That means it can be excreted with feces. So if we give broad spectrum antimicrobial agent means you are actually distracting, you have already distracted the microorganism in the gastrointestinal tract and they cannot deconjugate. So the estrogen can be eliminated. So like the serum concentration can be subtherapeutic because of like continuous elimination because we are interrupting the intrahepatic recirculation. So that means if we interrupt the intrahepatic recirculation, so what will be remaining will be like a small amount of estrogen and like maybe the progestin, but the progestin does not undergo intrahepatic recirculation. So most likely the concentration of the hormonal pill in the serum will be subtherapeutic to prevent pregnancy. That is why that is one possible failure. So broad spectrum antibiotics are usually with hormonal contraceptive. The mother is taking, she's supposed to take additional form of contraceptive, maybe like the barrier method that is usually recommended. This is one possibility. But not only that, if you give like hormonal contraceptive with enzyme inducer, the probability of failure is actually very high because enzyme inducer promote the metabolism and it reduces the therapeutic concentration in the serum, and ultimately there is a possibility of unwanted pregnancy. So those are like the most well-known cause of failure of contraceptive. Of course, like they're supposed to, adherence is very important. So if they don't take it properly, there is a possibility. Then apart from that, if you hear properly what Angela said, she's supposed to start like during the first day of menstrual cycle. That is usually recommended, or within the 5 days. Like the sooner the better. Like the recommendation is first day of menstrual cycle she's supposed to take. The sooner the better. But usually within 5 days of menstrual cycle is usually recommended. Remember, sometimes if we don't take it like within this period of time, hormonal contraceptive, even it will take like 7 days to be fully effective. Yeah. Because of that reason, we need to give proper instruction when a mother is taking hormonal contraceptive. They're supposed to initiate within the first day of hormonal contraceptive. And you have to take adequate information, like whether she's taking any broad spectrum antibiotic or any concurrent drug she's taking because of the possibility of drug interaction that can cause failure of the hormonal contraceptive. So those are the kind of information we need to be like equipped with at the pharmacist. Any other question, or maybe if you do have any other question, you can actually even maintain at the end. Okay, then can you continue, Surya? Surya?
Okay, I'm back. Sorry, I had internet connection issues.
No problem.
We'll continue with progestin-only pills. So we had said they are also known as the mini pill, and they're not as commonly used as the combined oral contraceptive pills. This is because they have a lower efficacy rate, and they also have increased incidence of the side effects that occur. But they have a lower risk of causing thromboembolic and cardiovascular disease compared to combined oral contraceptive pills. So this is because of the estrogen. Because now they are only containing progestin and they don't have the estrogen, the absence of the estrogen makes it better, lowers the risk of getting the thromboembolic disease. So they contain low doses of progestin, that is about 350 micrograms of the progestin derivative, such as norethindrone. Progestin, they are preferably administered to women who are 35 years and above, who are heavy smokers, where the estrogen is contraindicated. The women who are breastfeeding, they have hypertension, have valvular heart disease, and as an alternative to combined OCP prior to the surgery. So here for the 35 years and above and the heavy smokers is because they don't contain estrogen, and therefore there's no risk for thromboembolic disease. And for breastfeeding women is because progestin has been shown not to lower the breast milk levels. When you're taking the combined oral contraceptive pills and you're breastfeeding, the possibility of reducing the breast milk that you produce is heightened. And also, as an alternative to combined oral contraceptive pills prior to surgery is because we see the combined oral contraceptive pills have estrogen, and therefore there is a greater risk of getting thromboembolic disease when you go for surgery.
Angela, can I ask you a question, like before I forget?
Yes.
So what is the mechanism of action? How does combined hormonal contraceptive affect like the quantity of the breast milk?
So what I had read was that when you have the estrogen in the combined oral contraceptive pills, usually causes a decrease in the milk production for the woman. And when you take the progestin-only pills, because they don't have the estrogen and they only have the progestin, the milk levels do not go down.
Yeah, that means, so estrogen is like the culprit. Huh? So estrogen, yes, by the way, inhibit prolactin production from the anterior pituitary. That is why it is actually like the hormone that affects milk production if you give them. So estrogen can inhibit the release of prolactin, and prolactin is the main hormone that is responsible for milk production. Remember, oxytocin is for rejection, but prolactin is like for milk production. So estrogen affects what? The level of prolactin from the anterior pituitary, so that it reduces prolactin level in such a way it reduces milk production. So if a mother is lactating, progesterone only pill will be the drug of, or the contraceptive, or the drug of choice. Yes. Okay, continue.
So the examples of progestin-only pills, these are brand names. There's Camilla, there's Erin, there's Heather, there's Jolivet, there's NordQDQ, and there's norethindrone. So the mechanism of action, so because they contain only the progesterone, the progestin derivative, they block only to 60 to 80% of the ovulation cycle. However, the effectiveness is thought to be due to the progestin can thicken the cervical mucus by reduction in its volume and alteration of its structure, which impairs the penetration of sperms. There's also reduction of the size and the number of endometrial glands, causing an atrophic endometrium that impairs implantation. There's also reduction of ciliary motility in the fallopian tubes, therefore slowing the rate of ovum motility. So when you're administering the progestin-only pills, so they usually come in a 28-day pack, but these ones, unlike the combined oral contraceptives, they don't have the inert ingredients. So you should take them continuously without a break so that you can be able to prevent the pregnancy from occurring. So there are two types of this pill. There's 3-hour progestin-only pill. So it should be taken continuously every day, i.e. with no breaks between the packs, and must be taken within 3 hours of the same time as the first pill each day. Then there's the 12-hour progestin pill, which should be taken continuously every day and must be taken within 12 hours of the same time as the first pill. So when a pill is missed, the pill should be taken immediately, and backup contraception used for the next 48 hours and 7 days if you are using the 12-hour progestin pill. So in case one vomits within taking the pill, within 2 hours of taking the pill, they should take another pill straight away, as the progestin derivative may not have completely absorbed into your bloodstream by then. When changing from combined oral contraceptives to now the progestin-only pills, you should start on the day after the combined oral contraceptive pills course ends. And after childbirth, the pill should be started at any time after 3 weeks postpartum. Starting before 3 weeks will increase the risk of the breakthrough bleeding. So also for this one, you can also set an alarm so that you're able to remember when to take. And also, if you vomit, as you have seen, or you have even there's a place that was saying even when you have diarrhea and you've just taken the pill in 2 hours, within 2 hours, then you should take another pill. And when you miss a pill, because of the low efficacy rate, you should also use additional contraceptive methods for 48 hours if you're using the 3-hour pill, and 7 days if you're using the 12-hour pill. So yes, as I've said, yes. So the side effects, there's episodes of irregular, unpredictable spotting and breakthrough bleeding. Acne may occur as a result of the androgenic activity of the norepinephrine, headaches, weight gain, mood changes, breast tenderness and breast enlargement, nausea and vomiting, cysts on the ovaries, but these ones are harmless. They are usually harmless and they usually resolve by themselves. So there's no need to go to the hospital.
Okay, one addition apart from that, by the way, nausea and vomiting is very prevalent with the estrogen, the combined contraceptive, because estrogen normally promotes or activates the vomiting center from the central nerve system. So in principle, if the mother is actually complaining nausea, vomiting, as a result of the combined contraceptive, we're supposed to use the progestin-only pills. Huh? Yes, and the weight gain is really very notorious in majority of the contraceptive. Like the estrogen normally causes fluid retention, but the progestin, they do have like anabolic effect, as well as even the actually continuous fat deposition in subcutaneous tissues. So weight gain is really very challenging, especially with the hormonal contraceptive use. So because of this reason, like what the recommendation is, when a mother is taking oral contraceptive, they are supposed to actually consider like healthy lifestyle modification. So that is very important so that you will not add weight. You can continue, Angela.
So the drug interactions when you're taking oral contraceptive pills, they include, so the drugs that lower the effectiveness of the oral contraceptive pills are antibiotics such as rifampin, like you had explained earlier, anticonvulsant medications such as carbamazepine and oxcarbazepine and phenobarbital, antifungals such as griseofulvin, antiretrovirals such as ritonavir, and herbal medications such as St. John wort. So emergency contraceptive pill. So this is also known as the e-pill. It's taken within 72 hours of unprotected sexual intercourse when the female is not on any other form of contraceptive to prevent pregnancy. As it is not highly effective, it is not recommended as a regular means of contraception. That should be reserved for cases of rape and when the condom ruptures. Its mechanism of action is not fully understood, but it does not solely inhibit ovulation. So other mechanisms that it works by include effects on gamete function and survival, and also effects on implantation. So maybe the effects on implantation is that it impairs the implantation of the embryo to the uterine wall. So, when you're administering the e-pill, so there's the selective progesterone receptor modulators, such as ulipristal, which is effective up to 120 hours after unprotected intercourse. There's also mifepristone, which is in doses of 10 to 50 micrograms to 50 milligrams taken orally, and that it can be taken within 5 days after the unprotected intercourse. So plan B, or Postina, has 2 tablets of levonorgestrone, which is a progestin derivative, and each of the tablets contains 0.5 milligrams. 1 tablet is taken within 72 hours of unprotected intercourse, and the next tablet within 12 hours of the first. If vomiting occurs within 2 to 3 hours of taking the tablet, another tablet should be administered alongside an antiemetic. So this one, as we were researching, I found that it is more advisable to take the first pill within the 9 hours, because that is when the efficacy rates are really high. The longer you wait, the higher the chances of you getting pregnant even after taking the pill.
Yes. But before you go to the next slide, this one, the post pill, this is the most commonly abused one in the community setting. Then 0.75, if the strength is 0.75, they're usually 2. If it is 0.75, but nowadays even we do have like a strength of 1.5. That means like 1 tablet that should be taken at once. So if you go to the community setting, you can get like 2 tablets, but each of them are 0.75 milligram strength, or you can get like 1.5 milligram of levonorgestrone, which is a single tablet, but both of them are actually like emergency contraceptive. But 2 of them, they have to be given like, you can take them even at once, or you can take them like every 12 hours. Yeah, you can continue.
So the side effects are usually nausea and vomiting, headache, dizziness, breast tenderness, and menstrual irregularities or heavy bleeding. The heavy bleeding I read, this is because of the endometrial changes, and possibly when the implantation has already occurred. Therefore, it's like it is having an abortive effect. Yes.
But very unlikely, Angela. So by the contraceptive, not advisable. If someone is pregnant, you are not supposed to use. But sometimes they can be taken inadvertently. So according to the available evidence, there is no like teratogenic effect or abortion-like effect of contraceptive use during pregnancy, but it is not advisable. So according to the current studies I know, they don't have any effect on the fetus if you use it inadvertently.
So I'll take you through the combination patch contraceptive. Mostly the trade name is Evra patch. Although I recently saw it was banned in the US and it's going by the name Zunemax, although it's still being used in other countries. So it's a transdermal contraceptive patch that is a highly effective form of estrogen and progestin contraception. This is a combined hormonal contraceptive, which is 4.5 centimeters per square, that releases ethinyl estradiol daily along with norelgostromine transdermally into the bloodstream. So the contraceptive is designed to deliver 150 micrograms of norelgostromine and 20 micrograms of ethinyl estradiol daily for a 7-day period. But normally it contains, so that is what it delivers to the blood daily, but the patch contains 0.75 milligrams of ethinyl estradiol and 6 milligrams of norelgostromine. So the patch is composed of 3 layers. The adhesive and sex steroids are mixed together in the middle layer with a removable pill back layer below the middle layer and a tan-colored protective layer above the middle layer. So the patch is applied to unbroken skin and is usually replaced weekly for 3 weeks. And the areas that have been determined clinically that the patch can be adhered to is the upper outer arm, the buttocks, the lower abdomen, and the upper trunk, but you cannot put it on your breasts. So those are the areas that have been determined that you can adhere the patch to.
Joyce, this one, is it available in Kenya? I have seen it only in the literature, but I don't know about the availability locally.
No.
Do we have the patch? Anyone who encounter maybe in the community pharmacy?
So I've heard that it is available in Kenya and some people actually use it.
Oh, okay. Okay, good.
Okay. So the administration, each patch is worn for 7 days and replaced each week for 3 weeks out of every 4. So the cycle is for 4 weeks. So after 7 days, the patch is removed and a new one is applied to another skin site. So a withdrawal bleed occurs during the 4th week when the patch is not worn. That is when the menstruation occurs at this time. So it is important to remember to apply the patch on the same day for the 3 consecutive weeks. So that is the cycle. So week 1, you apply one patch. Week 2, you apply another one. Week 3, you also apply another new one. But on the 4th week, you don't apply it because that's when you're menstruating. So the mechanism of action, the patch works primarily by preventing ovulation. It suppresses the luteinizing hormone and the follicle stimulating hormone, which means there's no egg available for fertilization, so pregnancy cannot occur. It also alters the endometrium lining, so it's no longer like ready to receive an ovum. In addition, it also causes thickening of the cervical mucus, which inhibits entry and movement of the sperm to allow fertilization to take place. So these are the advantages and disadvantages of the patch. So advantages, it's that it protects against pregnancy. There's no interruption during the intercourse. It's easy to use, unlike the pills where you have to keep on taking the pill on a daily, but this one you use it only on weekly application. You can use the patch while doing normal activities, such as bathing, swimming, and exercising without it being interfered with. The disadvantages is that the prescription is required, physician visit is required, and it has side effects that include irritation at application site, headache, nausea, upper respiratory infection, and menstruation cramps. It does not also protect against HIV and STDs. Yes. So it's normally indicated and used mostly by women who desire an non-permanent contraceptive method and have no contraindication to use of estrogen or progestin containing contraceptive methods. So mostly for women who are not looking for contraception for a long time, something that is not permanent, only for a short while. So basically, this is what you cancel when you're providing the patient with this patch. So the woman can initiate the patch at any time in the cycle as long as pregnancy is reasonably excluded. But if the initiation occurs 5 days after onset of menses, a backup method should be used for the first days of the patch. Yani, if you start using the patch 5 days after your menses, you need to use up a backup contraceptive method, such as condoms, for the consecutive 7 days to come, so as to prevent yourself from getting pregnant. The same site should not be used when patches are changed. So during the week 1, if you use your arm, the next week you can use your abdomen, so as to prevent the reaction on the skin. Occlusive dressing and lotion should not be used where the patch is applied. And for its efficiency. Next. So when you delay, maybe when you're changing your patch, maybe you forget and you delay to like apply the patch. So with delay in patch changes beyond the scheduled date with the first patch application, of the first patch application of the patch becomes the new start date and further backup. So what this point means is during your first week, so when you're done with your first week and then during the second week, you delay to put your patch, what you should do is that day that you put the patch is your new start date, and you should start counting from that time. And a backup contraceptive method such as condom should be used for the next 7 days. And if you delay changing the second and third patch within the 48 hours of the scheduled date, the subsequent change date remain the same and no additional precaution should be taken, because it is assumed that the blood has adequate hormonal contraceptives for up to 9 days after application. So when you delay changing only the first patch, that's when you change your date. But when you delay changing the second and third patch within 48 hours, you don't need to change your date, and there's no backup contraceptive that is needed. Patch is applied becomes the new change date. So if your patch becomes fully or partially detached for less than 24 hours, it can be reapplied if the adhesive still works, or a new patch can be used with no change dates. So if it's within the 24 hours, you just put a new patch, or you can try to use the one that had detached if the adhesive tape is still working. But you should not use tape or anything to try and glue it to your skin, because maybe it has lost its adhesiveness, because the patch will not be effective. So, and also remember not to use it on irritated or abraded skin. So if the detachment exceeds 24 hours, a new patch should be applied and backup contraceptive should be used for 7 days, and the date of application becomes your new change date. Although detachment is very rare, because we even say that you can go to swim with it without it being detached. So also tell your patient that she may anticipate breast discomfort during the first 2 months. And vaginal spotting can also be spotted during the first 2 months. And do not flush your used patch in the toilet or a water system, but fold it and disperse it in the trash. So it's contraindicated in people with a high risk of thromboembolism, uncontrolled hypertension, or diabetes. People with prior stroke, ischemic heart disease, livers, and tumors that are estrogen dependent. In postpartum women, it should be delayed until 21 to 42 days due to an increased risk of thromboembolism. In obese women, the potential for the efficacy for the patch may be decreased and they may end up being pregnant. When I was researching it, I saw that if you're like heavier, the patch may not work. And if you're lighter, there's a higher probability the patch may work. And women with sensitive skin or dermatological conditions, they should abstain from using this patch. The side effects, they are the same as the oral contraceptive method. There's venous thromboembolism, there's dermatitis, is within the first 2 months, there's vaginal spotting and breast discomfort, and there's also nausea and vomiting. Any questions?
Any question? Maybe we can retain the question towards the end of the presentation. If we do have, you can raise. Any question? Okay, fine.
Okay, I will take you through the birth control implantation. This is another method of contraceptive. This is another contraceptive method. This one is a long-term birth control. Like the others, they have to use the first one we saw. They have to use it daily, like the pills, and then the patch is also for a short period of time. But this one is for long-term birth control, and then this it is a flexible white plastic rod, which is implanted on the arm, and then it's non-biodegradable. It's also 4 centimeter. It has 4 centimeter length and a diameter of 2 millimeter. It's, like I said, it's placed under the upper arm. It's hormonal implant, which is 99% effective. It's like I put the structure over there, the ethnogestrel. It's composed of basically it doesn't have estrogen but progesterone only. Next slide. So the method of or the procedure of insertion is first the patient have to lie down, and then the elbow, bend the elbow to near to your arm with whichever hand you prefer, and then your healthcare provider will groove between your biceps and triceps muscle to the inner side of your upper arm. Then they will inject a local anesthesia so you don't feel any pain while they insert the implant. And inserting the device too deeply will make it harder when the time comes to remove when the time for removal. Once the procedure is done, the healthcare provider will feel your arm to confirm, and then if needed, an X-ray can be an imaging of X-ray or ultrasound can be taken, and also then after that, after the healthcare provider has make sure that the patch is on the right position, they will put a bandage, a pressure bandage, and then you can remove it after 24 hours, but also keep a small bandage to keep it clean for Next slide. The mechanism of action of implant is, once the implant is placed under your skin, it releases a small amount of progesterone, and then this hormone works by by inhibiting, by giving pituitary gland, what is it called? Yeah, anyways, it send message to the pituitary gland so that it can tell the ovarian gland, the ovary, not to release any egg, and also to make the mucus in your cervical to be thicker, so that it can make the swimming of the sperm harder or difficult. The advantage of using implant, why do women choose the advantage basically to choose implant could be, the first thing is like the others, my group member has talked about, or the Dr. Amsalu talked about, the fact it doesn't have estrogen is a good advantage, because it's even reduced the thromboembolic risk, and also it's a choice for lactating mothers. So that's one advantage. Also, it will eliminate the need of interruption sex for contraception, and also can be removed at any time whenever the woman want to be fertile. Contraindication, the healthcare provider might say contraindicates the contraceptive implantation method if you have any allergy to the component of the implant. If you had a serious blood clot or heart attack or stroke before, have liver tumor or liver disease. The reason for liver is because it's contraindicated for liver disease is because it's excreted and metabolized by renal, by PY 40/50. So therefore, it's contraindicated to patients who have any condition with liver disease, have known or suspected breast cancer or history of breast cancer, have undiagnosed abnormal genitalia bleeding as well, then it's contraindicated on these cases. It's also contraindicated in the contraceptive implant isn't contraindicated for the use of women who are overweight. Okay, there's no research or there's no proof that says it's contraindicated to overweight women, but it's good to, it's not advised for patients who are obese or the BMI is above 30, just to be on the safe side. And then you should, if a patient or if a woman is using this contraceptive method and have any risk factor of blood, like if they face any challenge or conditions, and pulmonary embolism or any swelling anywhere, then they should report to their healthcare provider, or they should seek for attention, health care attention. The drug interaction, certain medications and herbal product may decrease the level of progestin in your blood, so it might make it ineffective. The medication known interaction with contraceptive implant includes some seizure medication, certain sedatives, some HIV medication. Example, we can take protease inhibitors like ritonavir, for example, can be have a drug-drug interaction with that of the implant contraceptive. Like I said, any drugs which can cause a reduction of or increase in progesterone can have any drug interaction, because like I said, the implant contraceptive method is metabolized and excreted by the renal. Next slide. Side effects are, it's the good thing about this drug is, like I said, it's a long contraceptive method, and then also it doesn't have estrogen. It doesn't contain any estrogen, which means the thromboembolic risk could be reduced, but there are other side effects. The common one is bruising, pain, scarring, or bleeding at the site of insertion. And then Also, they might be irregular menstrual cycle, which could be lighter or heavy, or even they might not have any menstrual cycle or any menstruation. Also, the minor other side effects could be headache, breast pain, nausea, weight gain. These all are related to the hormonal effect. And then another ones could be like ovarian cyst, and infection where the implantation was inserted also could be other side effects that are seen in implant contraceptive.
Right, so injectables.
Okay, fine. So, like before you start, but the implanters already talked about. We do have the 3 years, the 5 years, and do we have 10 years? I think the 10 years are actually the intrauterine devices. So those are like the most common type of long-term hormonal contraceptives. Huh? Okay, now we can continue.
Injectables. Injectable contraceptives contain hormonal drugs that provide women with safe, highly effective, and reversible contraception protection. They have been developed to like reduce the need for women to take pills daily. All injectable contraceptives given intramuscularly as oily solutions are slowly absorbed into the bloodstream from the injection site, with the body maintaining a sufficient level of hormone to provide contraception for 1 to 3 months, depending on the type of injectable used. They are highly effective and used with over 40 million women so far. There are mainly 2 types of injectables used. Progesterone-only formulations, which contain a progesterone hormone that is effective for 2 to 3 months, or combined formulations which contain both progesterone and estrogen that is effective for only 1 month. Progesterone-only formulations, only the long-acting progestin injections are in use. They're injected once in 2 to 3 months, depending on the steroid and its dose. 2 compounds have been marketed, which is DMPA and norethindrone. And the DMPA is injected after every 3 months, and the norethisterone is injected after every 2 months. The mode of action is the immediate action of progesterone-only injectables is to thicken the cervical mucus so as to prevent the sperm to penetrate or swim to the egg or the ovum. It also impairs ovulation. There are additional changes in the endometrium that makes it unfavorable to implantation. However, the first 2 effects make fertilization highly unlikely. This is just pharmacokinetics. DMPA is given at 3 months interval, while norethindrone is given at 2 month intervals. And DMPA is usually repeated after every 3 months, but the norethindrone is repeated after every 2 months because it's shorter acting, and sometimes the failure rate is higher than the one who is administered with DMPA. Adverse reactions, there's menstrual irregularities associated with the disruptions of the menstrual cycle, including amenorrhea, prolonged menses, spotting between periods, and heavy bleeding. Less than 1/3 of women receiving DMPA report having normal menstrual cycles during the first year of use. Amenorrhea is the most common side effect, and its occurrence increases with duration of use from about 50% of DMPA users by the end of 1 year. Heavy bleeding is uncommon, and prolonged bleeding is seldom heavy enough to be a threat to health. Any woman who reports prolonged or heavy bleeding may need to be evaluated for anemia. Anemia treatments include nutritional advice and appropriate dose of iron tablets. Treatments for heavy bleeding include non-aspirin, anti-inflammatory drugs such as ibuprofen, short-term use of combined oral contraceptives or estrogen, or early administration of the next injection, which is not sooner than 4 weeks after the previous injection. If these menses are not effective or the woman's health is threatened, it should be discontinued immediately. But women who use the second one, the non, are likely to experience amenorrhea than the ones who use DMPA. It's not suitable for adolescent girls and lactating mothers. In addition, use of DMPA is generally restricted to women who are likely to use other contraceptives immediately. There is weight gain, headache, and dizziness are the next most common side effects reported. Most users of progesterone oil injections are put on weight, and this is a common reason for discontinuation. The average DMPA user gains are to 2 kgs in the first year, and some users continue to gain weight thereafter. In clinical trials, between 3% to 19%, as I saw, of users of injectables have reported headache and dizziness. Few women discontinue because of these reasons. There is also menopause-like symptoms, which include hot flashes, vaginal dryness, and reduced libido due to low estrogen levels caused by gene suppression. Possible carcinogenicity. Studies have indicated a small increased risk of breast cancer in some younger women following initial exposure. They have also confirmed a substantial protective effect against endometrial cancer. There is also bone mineral density may decrease after 2 to 3 years of use, especially with the DMPA, due to low estrogen levels caused by gene suppression. There's also effect on metabolism. The only metabolic effect of undoubted clinical importance is weight gain, minor alterations of lipid metabolism, fluid/nitrogen balance, glucose tolerance, steroid metabolism, and immune functions have been recorded but seem to be of no clinical significance. There is also cardiovascular effects. No cardiovascular effect is seen, however. Further investigation is needed into a possible increased risk of stroke among women with high blood pressure when using the injectables. The DDIs are if a woman on hormonal contraceptives takes a drug or herbal product that induces enzymes, including CYP3A4, that metabolizes contraceptive hormones, additional contraception or a different method of contraception should be used. Also, drugs or herbal products that induce such enzymes may decrease the plasma concentration of contraceptive hormones and may decrease the effectiveness of hormonal contraceptives. Some drugs or herbal products that may decrease the effectiveness include barbiturates, carbamazepine, cresofulvin, HIV protease inhibitors, and non-nucleoside reverse transcriptase inhibitors. Antibiotics also, there have been reports of pregnancy while taking hormonal contraceptives and antibiotics, but clinical pharmacokinetic studies have not shown consistent effects of antibiotic on plasma concentration of synthetic steroids. Yeah.
I'll take you to the contraceptal vaginal ring. Sorry for the earlier interruption. So I'm going to rush through because we don't have so much time. The combined contraceptive vaginal ring is a once in a month method of hormonal contraception. And then those are some of the brand names: the CCVR, NuvaRing, Oregon, OSS, the Netherlands. The contraceptive ring delivers 120 micrograms of etonogestrel and 15 micrograms of ethylene estradiol daily through the vaginal mucosa. That's for the NuvaRing. The ring is flexible and transparent and has a diameter of just over 2 inches. The ring is inserted vaginally and kept in place for 3 weeks in a row. After 3 weeks, the ring is removed for 1 week and then a new ring is inserted. For extended use, the ring-free week may be skipped by inserting a new ring on week 4. Next slide. Oh, and then also after removal of the ring, there's usually a period of menstruation after 3 days. And then vaginal administration of contraceptive hormones with NuvaRing has the advantage of avoiding gastrointestinal absorption and hepatic fast pass metabolism, unlike the pills, but does not produce evaluated uterine concentrations of ethylene estradiol and ENG compared with combined oral contraceptive. Unlike the patch, the ring has not been shown to increase venous thromboembolism risk or have reduced efficacy in obese women. So that is an advantage of the ring over the patch. When it comes to efficacy, the failure rate for the contraceptive ring is 0.3% with perfect use and 8% with typical use. So the ring has good adherence rates and lower ethylene estradiol levels, and it would be a good contraception if one is comfortable with using it. Next. This is the procedure for insertion. The ring may be placed anywhere in the vagina, so one does not need to worry about its exact position. To insert the ring, one should compress it so the opposite sides of the ring are touching and gently insert it into the vagina. If one feels discomfort with the ring, it probably has not been inserted into the vagina far enough. Most women do not feel the ring once it is in place. Also, for women who prefer to use tampons over pads during their menses, it does not usually affect the ring, and also there are no interruptions during sexual intercourse. And next slide. This is the procedure for removal. To remove the ring, one should grasp the ring between two fingers or hook one finger inside the ring and pull it out. Menses will usually begin within 3 days of removing the ring. If the ring slips out, it should be rinsed with lukewarm water and reinserted. If the ring is out for less than 3 hours, you need to use a backup contraception. You do not need to use a backup contraception, but if it's out for more than 3 hours, then you will need to use a backup contraception, and it should be used for 1 week. Next slide. So the precautions and contraindications. The ring is formulated to contain approximately 35 days of medication, but it's not usually advised to use it for more than 21 days. If it has been placed for more than 4 weeks, you should remove it, confirm that you're not pregnant, and then reinsert a new one and use a backup contraception for 1 week. The contraceptive ring should be inserted anytime during the first 5 days of the menstrual cycle or inserted using the quick start method. Backup contraception should be used for the first week. When changing from the combined oral contraceptive, one should insert the ring within 7 days of the last active pill, and then no backup contraception will be needed. If the ring is believed to have the same contraindications and precautions as the combined oral contraceptive. So these are some of the side effects, which are also kind of common with the ones that we have seen, except this one has vaginal infections if the ring has not been inserted well or if it was contaminated before insertion. And then there's irritation, discharge, headache, weight gain, and nausea. And yeah, that's our presentation. Are there any questions?
Okay, thank you so much. Any